Hello everyone, this is Rob Pass, the host of the podcast. This week we'll be doing a replay from an episode from 2 years ago on the topic of ANSEF or Cefazolin dosing during cardiovascular surgery and what makes sense in regards to how to properly dose it to achieve appropriate levels for prophylaxis. I hope you all enjoyed this episode, and I'll be back next week with a brand new episode. Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine. Thank you very much for joining me for our 205th episode of the podcast. I hope everybody enjoyed last week's episode on the concept of fetal counseling. We spoke with Assistant Professor of Pediatrics at the University of Texas Southwestern, Jenna Keelan. For those of you with an interest in fetal cardiology and fellow education, I'd recommend you take a listen to last week's 204th episode. As I say every week, if you'd like to get in touch with me, it's easy to remember my email. It's pediheart@gmail.com. This week we move on to the world of cardiovascular surgery, and we'll be reviewing a very interesting practical paper. The title of the work is Perioperative Cefazolin Prophylaxis in Pediatric Heart Surgery, a prospective cohort study. The first author of this work is Jessica Suna, and the senior author is Nelson Alfonso, and most of the authors come to us from the University of Queensland in Brisbane, Australia. When we're done reviewing this paper, we're very lucky to have Dr. Jessica Frye, who is the Clinical Pharmacy Coordinator in the Pediatric Critical Care Unit here at Mount Sinai Kravis Children's Hospital, to join us to discuss this work. Therefore, let's get straight onto the article and then our conversation with Dr. Frye. This week's work comes to us from Australia and is on the practical topic of antibiotic prophylaxis for cardiac surgery. The work begins with some comments about how infections in the perioperative period are generally quite serious, and the possible effects of these can be longer lengths of stay and, of course, more morbidity and even mortality. There are many works demonstrating the value of antibiotic prophylaxis for surgery, but the authors explain that there are very few pediatric studies supporting the use of Cefazolin for pediatric heart surgery, and they explain that it is presently unclear if the routine dosing regimens that have been used in pediatrics as adapted from the adult world produce sufficient antimicrobial concentrations in children, especially when considering that cardiac surgery involves the use of cardiopulmonary bypass and all of its possible effects on dilution, sequestration, hypothermia, and altered physiology. There are several studies on this topic in adults, but not too many on children, and so the purpose of this work was to investigate the effects of cardiopulmonary bypass, ultrafiltration, and hypothermic circulatory arrest on unbound serum cefazolin concentrations in patients less than 16 years of age at the time of cardiac surgery for congenital heart disease. And the hypothesis was that these concentrations may drop below the minimum inhibitory concentration, or MIC, of common pathogens during the operative period. This was a prospective observational study at a tertiary pediatric hospital over 5 years, from 2013 to 2018. Patients aged 1 day to 16 years who were scheduled for elective cardiac surgery were eligible, and those who had a prior existing infectious disease were excluded. They had a number of cohorts in this study, and these were neonates, 0 to 30 days, infants, 31 days to 365 days, and children 1 to 9 years of age, and then children over age 9, those who had a prolonged bypass of greater than 120 minutes, and finally those in which hypothermic circulatory arrest was used. The authors explained that the dosing of Cefazolin was fairly usual, with an upfront bolus of 50 milligrams per kilo prior to the incision, up to a maximum of 2 grams. And then the patients were given a dose of 25 milligrams per kilo body weight every 3 hours during surgery, and then 25 milligrams per kilo every 8 hours for the first 24 hours following surgery. All patients received ultrafiltration, and the method of this is explained by the authors. Patients also received hypothermia and were managed using a pH strategy below 28 degrees, with ice placed around the head and blood continuously circulated through the bypass circuit. Participants were thought to be treated with deep hypothermia if the body temperature was recorded at less than 25 degrees Celsius. A total of 12 essential blood draws were made, and there's a nice table, Table 1, which shows when they were drawn. And basically they were drawn after and before most of the doses, up to a final measurement obtained 5 minutes prior to the third post-operative dose. In order to determine if the level of drug was adequate, the authors had to decide which organism was most likely to affect a postoperative patient and what the MIC, or lowest concentration that will inhibit visible growth of the bacterium, would be, and they decided upon Staphylococcus aureus or epidermidis, which would be the most common organism for this study, and used a target MIC for Cefazolin of Staph aureus of 2 milligrams per liter. Finally, the authors explained that for this work, they used the STS definitions of infection, and so superficial wound infection was defined as an infection involving the skin and subcutaneous tissue of the incision with purulent drainage from the superficial portion of the incision. Organisms isolated from the superficial portion of the incision, pain, swelling, redness, heat, and surgical reintervention of the superficial portion of the incision, or a diagnosis of superficial wound infection by the treating doctor. Sepsis was defined as evidence of serious infection accompanied by a deleterious systemic response. And on to the results. Overall, there were 68 patients enrolled, but 4 were excluded due to either protocol deviations or sampling errors, and so there were ultimately 64 patients in this work. There were 21 newborns, 21 infants, 12 children, and 10 older children. The median weight was 7 kilos and body surface area 0.3 meters squared, with a median bypass time of 110 minutes, and 48% were male. Thus, to summarize, 66% of the patients in this work were less than a year of age. And what were the most important findings? Well, first and perhaps most important, 100% of patients had Cefazolin levels equal or greater than 2 milligrams per liter during the entire surgical procedure. However, importantly, 30% or 19 total patients failed to achieve an MIC level in the first 24 hours after surgery. The authors describe the levels during surgery and note that they fell about 38% between skin incision and 30 minutes of instituting bypass, from a median of 54 to 21, and the concentrations would fall until an additional dose was administered 3 hours into the operation, and they showed that the median level was still 28 milligrams per liter at skin closure, which was a bit more than half of the level measured at incision time. 7%, or 5 patients, were identified to have postoperative infections, and these patients were a median of 6 days old, with a median bypass time of 177 minutes. 3 of these infants had cyanotic lesions, with the other 2 having either interrupted aortic arch or aortic arch hypoplasia with VSD. 1 patient is described as developing sepsis, but not related to the wound, and this was a 4-day-old with hypoplastic left heart syndrome, with a surgical duration of 301 minutes. The authors state, and I quote, "Maintaining Cefazolin concentrations above the MIC was not related to postoperative superficial wound infection or sepsis." The authors found that older age was associated with lower median unbound Cefazolin concentrations in the post-op period, but that those infants that had hypothermic circulatory arrest actually had higher levels. Longer bypass times were not associated with differences in Cefazolin levels. The sample size was too small to perform a multivariate analysis, but using univariable analysis, failure to achieve unbound serum Cefazolin concentrations equal to or greater than 2 grams per liter in the 24 hours after surgery were associated with older age, larger body surface area, larger body weight, and delayed sternal closure, as well as reduced creatinine clearance. In their discussion, the authors state, and I quote, "Our study found that although Cefazolin concentrations were markedly diluted on initiation of bypass, the protocolized loading dose was adequate, particularly when combined with routine 3-hour redosing. This study identified that antimicrobial prophylaxis in the postoperative period was inadequate in 42% of patients. The reasons for this are unknown." The authors explain how many of the findings were similar to older adult studies, and comment on the fact that older, larger children had lower Cefazolin concentrations, and how prior works have also demonstrated these factors to be associated with lower levels, indicating that standard dosing of Cefazolin, as performed in this work, may be insufficient. They wonder if the reason that smaller patients had higher levels may be due to the lower cardiac output state of sicker newborns and smaller children after surgery, resulting in renal clearance problems. They comment on how longer bypass times were not associated with lower levels of antibiotics, and believe it is due to their protocol of every 3-hour redosing of antibiotics during surgery. In regards to limitations, the authors comment on the small sample size and its impact on inability to perform a multivariable analysis, and also that the use of MIC rather than clinical outcomes of infection was a limitation. And so they conclude, and I quote, "This study demonstrates that the standard Cefazolin prophylaxis regimen used in our hospital was sufficient to maintain target concentrations above 2 milligrams per liter in the operative period. Postoperative dosing of 25 milligrams per kilo every 8 hours for the first 24 hours after surgery did not appear to maintain target concentrations above the MIC of 2 milligrams per liter in 70% of patients. Age, body weight, and body surface area, creatinine clearance, and delayed sternal closure were significantly associated with failure to achieve adequate unbound serum cefazolin concentrations. Future studies are needed to identify the most appropriate antibiotic prophylaxis regimen that will maintain drug concentrations consistently above the MIC in the postoperative period for children undergoing cardiac surgery." The authors conclude by suggesting the possibility of a 24-hour continuous infusion of cefazolin, but they wonder if this might contribute to the development of antibiotic resistance over time. Well, this is not what might be viewed as a high science paper, and the number of limitations are significant, with the most clear one being whether lower drug concentration levels obtained are in fact related to the development of postoperative infections. There was no way to determine this given the small sample size, but one might imagine that this would at least be a factor. There are so many factors that go into the postoperative infection, and reducing these is always of paramount importance. When there's an uptick in infection, in my experience, fingers start pointing. Is it the conduct in the OR? Is it in the ICU? Who's responsible for maintenance of ICU sterility and proper continuous care in this regard? This is a challenge, and it has always interested me to see the sheer number of individuals who are physically touching patients in an ICU over a period of time. And I've always had the suspicion that reducing these interactions to a minimum would have an important impact over time. But again, this is almost impossible to measure. I do believe that despite being unable to draw a line between these findings and infections after surgery, it's clear that it makes little sense to have inadequate levels of antibiotics in the postoperative period. If we're going to use these agents, we should, at minimum, be confident that our dosing regimens are appropriate to reach levels that we believe would be effective. And if such a large number of patients are not hitting appropriate MIC levels at times in the postoperative period, it will be even harder to identify how to reduce infections after surgery if we can't remove this variable. There's a fair bit to unpack here, and so in the interest of time, I'll step off the old soapbox and let's move on to our interview with our guest. Joining us now to discuss this week's work is the Director of Pediatric Critical Care Pharmacy at my own hospital, Mount Sinai Kravis Children's Hospital, and that is Dr. Jessica Frye. Dr. Frye received her PharmD degree at Rutgers University and completed a pharmacy residency at the same institution. Prior to this present position, she was the clinical pharmacy manager for the PICU at Montefiore Medical Center, and she's been at Mount Sinai for nearly 3 years in her role as the clinical pharmacy coordinator in the Pediatric Critical Care Unit here at Mount Sinai. I can say from rounding many days and weeks with her that I learned something new virtually every single day we round together, and so I'm particularly excited to share her thoughts with you this week on this work. Welcome, Jess, to the podcast. I'm here now with Jessica Frye. Jessica, thank you so much for joining us this week on the podcast.
Yeah, thanks you for having me. Great to be here.
Really appreciate it. For those in the audience, Jess really saved me this week. We're having a little difficulty getting one of the authors of this week's paper to join us, but then I thought to myself, well, I have a pharmacologist right at my fingertips. What am I wasting my efforts? So thank you very, very much. Jess, the first thing I wanted to start talking about was MIC levels as a goal of antibiotic dosing. The authors of this work clearly use the MIC level as the measure of whether or not they had appropriate or adequate antibiotic dosing. Do you believe that not achieving this level means that the dose used was not functional or effective or optimal?
Yeah, so really with antimicrobial prophylaxis, the real goal is going to be the prevention of infection.
Yes.
But commonly drug concentrations and pharmacodynamic data are used as surrogates. Cefazolin, which is a beta-lactam antibiotic, the target for that's going to be associated with therapeutic efficacy is time over MIC. So not necessarily if a particular concentration is reached, but the amount of time that the concentration remains above the minimum concentration to prevent growth, or the MIC. So the authors do mention in this paper that for surgical prophylaxis, the optimal target is going to be that you want to have the time over MIC from the incision to closure remain above that particular concentration. So in this situation, you're going to have 100% of your concentration above the target MIC for the time of surgery. In the post-operative period, so outside of the operating room, if we're just talking about standard beta-lactam dosing, that target is closer to 50% that you want that concentration to remain above the MIC, with the range of being from 40 to 70% in the literature. So, to say that the post-operative dose, because it wasn't achieving a target MIC for the entire dosing interval, we don't really know that if this is necessary in the post-operative period, like we do know that it's necessary in the intraoperative period.
I see. So one could make an argument that actually these data suggest that the dosing's working quite right because you're getting the percentage time right when you need it and also right in the post-op period as well.
Yeah, I think it's hard to know for certain because there's not a lot of guidance in the post-operative period what that target should be. So I think it's definitely a great stepping point to discuss that. But like you mentioned, definitely in the intraoperative period, they showed that their dose did achieve this target.
Yeah. Thanks. This work suggests that the presence of a delayed sternum was associated with a lower level of antibiotic. As a pharmacist, I was wondering if you had any thoughts on why pharmacologically this might be. I would have thought that someone who has an open sternum almost by definition is in low cardiac output, might have lower renal perfusion, and actually have higher levels of antibiotics, and yet they seem to suggest that the levels were lower. Do you have any thoughts on why this might be?
Yeah, you make a good point that you would expect a decreased drug clearance in this patient population. There is a phenomenon in critical illness known as augmented creatinine clearance. So you actually have an increase in clearance through the kidney of drugs. However, in that, you would expect high creatinine clearance calculations, where in this patient population, the post-operative creatinine clearances were in the 40s. So I wonder if vitamin distribution is actually playing more of a factor here. We know in critical illness, there's significant changes in vitamin distribution of medications, specifically hydrophilic medications, with capillary leak and changes in fluid status. So Cefazolin is a hydrophilic medication, and with increases in total body water, you would expect an increase in vitamin distribution and potentially a decreased concentration as well.
I see. Well, that makes great sense. You see, you are supporting. You didn't get to hear my preamble to our interview, but I said that I learned something on virtually every single interview, every single rounds that we go on, and so here we are already. I'm learning a lot of things, so thank you. I was wondering, Jess, are you swayed by these findings in regards to dosing? Do you think that their findings suggest that we should consider using a different dosing regimen, maybe?
I'm definitely intrigued by it. I don't know if I'm swayed quite yet. I think what I found most interesting was the initial dose that they used for the dose prior to incision. So in this study, they used 50 milligrams per kilo. The current recommendations for pediatric surgical prophylaxis recommend a dose of 30 milligrams per kilo with Q4-hour doses following, depending on the length of the procedure. So I think they definitely showed that this 50 milligram per kilo dose followed by 25 milligrams per kilo Q3 achieved the pharmacodynamic target that we're looking for. But I would like to see how that compares to 30 milligrams per kilo, which is definitely the more common dose that's utilized. There's definitely variation in the literature, but like I said, 30 milligrams per kilo is probably more common. And then when it comes to the post-operative dosing regimen, we kind of discussed this a little bit already, but there's not a lot of great guidance out there about what that should look like. So I think this study really is an important step in determining what that should be. And I think in the future, studies should look at different Cefazolin dosing regimens and what the time over MIC target should be in the 24 hours following cardiac surgery.
I see. That makes good sense. Well, for those in the audience, it's quite late at night. Jess was nice enough to conduct this interview very late because of my crazy schedule today, so thank you. So I'll finish up with our final question. The work ends with a suggestion by the authors of potentially considering the use of a continuous infusion of antibiotics after surgery as a possible means of maintaining an adequate level. And I guess it's sort of is similar to what you were saying about always having a high percentage of time with a good level. Are there any data on actually doing this? Like, does anybody actually give continuous IV antibiotics? I don't remember ever seeing that in the pediatric ICU, but, I haven't worked in all of them. What's the data on something like that?
Yeah, definitely. There is data to support this. Like you mentioned, and we've talked about already a few times, the rationale is that you want to maintain the most amount of time over that MIC with your drug concentration. There are logistical issues with that. Obviously, the biggest one is going to be access, which is always a problem in the pediatric patient population, and compatibility with other medications. There's also issues with drug stability for long periods of time. So more commonly, this is actually done as a prolonged infusion versus a continuous infusion. So instead of giving the dose over 30 minutes, you would give the dose over 3 to 4 hours. And again, this is just to optimize the time over MIC. Most of the data in pediatrics has really focused on the critically ill patient population, or patients with cystic fibrosis. But maybe there's a use for it in cardiac surgery.
Interesting. Yeah, I definitely think your point about the vascular access is a very real one. And if the drug is not compatible with a lot of other agents, right, we're always asking you, can I mix this and this and this? And we're all kinds of crazy combinations in these central lines. I'm guessing Cefazolin and a lot of antibiotics don't mix terribly well with certain other drugs.
Yeah, definitely a lot of sedatives are always going to be an issue. So I think the interim in between the continuous infusion and the intermittent dosing is that prolonged infusion if you have difficult to treat organisms or high MICs.
I see. Well, Jess, I can't thank you enough for joining us this week. You are the second pharmacist to join the podcast as a guest. Now you're the second one where I'm walking away saying, why am I waiting so long for the next pharmacist? So thank you very, very much, and thank you so much for helping with our patients at Mount Sinai and back when I was at Montefiore. It's a great pleasure and an honor to work with you, and thank you so much for joining us this week.
Thank you a lot.
Thank you. Well, Dr. Frye shared many insights into how we should be thinking about dosing of antibiotics. And if you're like me, I think you probably have a much better insight into the findings of this week's work based on her framework that she just outlined for us. It may seem as if I'm joking in this regard, but I'm dead serious in saying that the role of the pharmacist on rounds in the PICU and CICU just cannot be overstated. Their understanding of pharmacokinetics and dynamics and the role of physiology on the drugs and levels and efficacy of these agents is just an invaluable resource. For those of you who might want to hear our other pharmacy guest, I'd recommend you listen to episode 179, when Dr. Caroline Hayrand of Primary Children's Hospital spoke with us about the use of bivalirudin for pediatric VADs. Just like then, I find myself learning all manner of things from Jess Frye tonight. I'd like to thank her again for her contribution, and I hope you enjoyed her comments as much as I did. This month, the Metropolitan Opera is performing the great Puccini opera Turandot, and the tenor singing Kalaf is the young Korean Sukjong Baek, and my chairperson, Dr. Lisa Satlin, who's also a very big opera fan, tells me that his singing was extraordinary. To note the performances of this opera at the Met this week, I thought I'd play the very famous aria Nessun Dorma, this time sung by another great Metropolitan Opera singer, the all-time great Richard Tucker, in a live television performance from the 1960s. Tucker had an indestructible vocal technique, and I've read that he had a very large voice that pealed over the entire hall, enveloping it in beautiful sound and tone. Thank you for joining the podcast for this replay episode, and thanks once again to Jessica Frye, our guest. I'll see you all next week.
Nessun dorma, nessun dorma. Tu pure, o principessa, nella tua fredda stanza, guardi le stelle che tremano d'amore e di speranza. Ma il mio mistero è chiuso nel